Good afternoon, and thank you for the opportunity to present. We have nothing to disclose, except I guess about 2 weeks ago we found out that Dr. Mellinger was going to be the moderator for this session, but was also involved in the study as well. So a little unusual circumstance there, but with over 350,000 ventral hernia repairs and approximately 800,000 inguinal hernia repairs performed annually in the United States, hernia repair represents one of the most common operations performed by general surgeons. Readmission status is an important clinical and economic component of healthcare outcomes. Socioeconomic disparities have been associated with differences in anesthesia during hernia repair, hernia recurrence rates, and post-op complications. However, the association of socioeconomic status with readmission rates after hernia repair has not been well studied with national level data in the US. Therefore, the aim of our study was to evaluate association of socioeconomic status with 30 and 90-day readmissions using the nationwide readmissions database. We performed a retrospective cohort analysis study evaluating laparoscopic and open ventral and inguinal hernia repairs by using the nationwide readmissions database from 2016 to 2017. Patients were selected from this database by using ICD-10 codes that corresponded with CPT codes for laparoscopic and open ventral and inguinal hernia repairs. One-to-one propensity score matching was conducted between patients that were readmitted and patients that were not readmitted. Then a multivariate logistic regression was performed using confounding variables, including hospital setting, key comorbidities, urgency of repair, socioeconomic status, and payer status. The likelihood of 30 and 90-day readmissions were calculated using odds ratio, and p-values less than 0.05 were considered significant. From the analysis at 30 days, our results showed a total of 214,089 hernia repairs performed. 3,708 patients were excluded due to an index mortality. The readmission rate was noted to be 11.6%, and of the included cases, 49.8% were elective and 50.2% were emergent. Of note, in the emergent repair group, Medicaid and low-income patients were statistically more likely to present in an emergent fashion. This table shows the results of patients after propensity score matching and weighing for 30-day readmission analysis. There was no statistical difference between the two groups in age, sex, and comorbidities. This table shows the results from the multivariate logistic regression for the 30-day readmission group. Those patients that underwent a laparoscopic procedure were 35% less likely to be readmitted. This was the strongest association with readmission when looking at the other variables. Those patients with lower socioeconomic status were more likely to be readmitted, as Medicaid patients were 25% more likely to be readmitted, and low-income quartile patients were 13% more likely to be readmitted. The type of hospital setting was also associated with readmission, as hernia repairs performed at teaching hospitals and urban hospitals were less likely to be readmitted. And lastly, the elective and weekday hernia repairs were less likely to be readmitted. For the analysis at 30 days, our results showed a total of 175,253 hernia repairs performed. 3,043 patients were excluded due to an index mortality. Of the cases included, 49.4% of hernia repairs were elective and 50.6% were emergent, and the readmission rate was noted to be 17.9%. This table shows the results after propensity score matching and weighing for the 90-day readmission group. And again, there was no statistical difference between the two groups. This table shows the results for the multivariate logistic regression for the 90-day group. And just like the 30-day group, those patients that underwent a laparoscopic procedure were less likely to be readmitted, and again was the strongest association with readmission. We again see that lower socioeconomic status was associated with readmission, and similar results were seen at 90 days in terms of the hospital setting and elective weekday cases being associated with less likely chance of readmission. The strengths of the study include a large national database population to make the study high-powered, and more likely to show a statistical difference if present. We also wanted to examine 90-day readmissions, as up to 40% of readmissions may occur after the 30-day period. With this being said, there are several limitations of our study, one being a selection bias, as the reason for laparoscopic or open repair is unknown, the size of the defect is unknown, and simple laparoscopic cases may not need admission to the hospital. And lastly, there were confounding variables that were not examined in our study, and those include but were not limited to race, ethnicity, educational level, and smoking status. In conclusion, this study is the first to our knowledge that employs the nationwide readmissions database to document that a patient's socioeconomic status is an independent predictor of 30 and 90-day readmissions for ventral and inguinal hernia repairs. Additionally, as confirmed in other studies, lower socioeconomic status patients are more likely to present in an emergent fashion. And the big thing is that this data supports the focus with efforts towards mitigating this socioeconomic status disparity by potentially promoting minimally invasive techniques, enhancing access to elective cases, and systematic approaches to perioperative care for this population in order to enhance overall hernia outcomes. Thank you.